Hey, good morning and welcome to UNC here in Chapel Hill, North Carolina. My name is Stuart Grant.
And I am Monica Nanda.
So we're two regional anesthesiologists at UNC, and we are here to celebrate World Day of Regional Anesthesia and Pain Medicine. And a lot of thanks has to go to the president of ESRA, Elena Moki, whose vision this is. And I've been up just looking at the feed and started in Hong Kong about 18 hours ago, people with live events. So that was my yesterday, their Saturday. Fantastic from there, and watched people around the world as time's progressed take part in this through Asia, through Africa, Europe. And it's now good morning here in North America. I know it's the evening for some people taking part in this. And what we want to do is put together a live scanning workshop. We have got the YouTube feed. We have got a chat box to the side. Please let us know what you've done to celebrate this for First World Day of Regional Anesthesia. We've had a couple of comments already, so we're going to get going with some of the requests and some shout outs to folks who let us know. I think we'll just get into it, then we'll talk a little bit more about what's going on for the day. But Monica, why don't we start? The first request we saw, somebody was early yesterday, they asked, can you scan the brachial plexus, axillary brachial plexus block? And what they asked for is the individual nerves. So let's talk about where they come from, where they go to. So Monica's going to slip the side here and start scanning. We have got the fantastic scan cam, which Mike, if you want to get the light on that, and then we are going to switch to that. So we're going to have a little shot of let's find on our model. Let's find our the skin in the armpit so we can see where Monica's going to put that ultrasound probe.
Okay, so first we're going to scan for the axillary brachial plexus block. You want the arm to be abducted 90 degrees, and I'm going to put the probe right in the axilla, right here. And we are going to look at the screen here. Left is lateral, and I'm sorry, left is superior and right is inferior. I'm going to adjust some of the settings on this ultrasound here. And what we're looking for, the very first structure, is the axillary artery, which is right there in the center, pulsating in the background. So we're going to get the arrow going here. Okay, so let's point to that's the axillary artery, and that's the axillary vein right there. And you can see if I let off the pressure, I see more than one vein. And I think we need a little more gel, which I will get here. Okay. All right. So axillary artery, axillary vein right there, and letting off the pressure, I see one more vein popping up right there.
Oh, there's a second, really superficial.
Absolutely. And let's identify some of the structures around it. Right underneath the artery, you see that big muscle, vascular structure. That's the conjoint tendon. That's a combination of latissimus dorsi and teres major coming and inserting on the humerus right there.
So this is the bony humerus at the bottom?
Yes.
Yep.
And this is where you need to be. You need to be at the level of the conjoint tendon, because this is where your radial nerve will reliably be underneath the axillary artery.
So let's explain a little bit about this. So the question was, can we see the individual nerves? And Monica, you said this is really important. I agree. So let's scan down the arm, a little bit distal on the arm, and we're going to look at this muscle and see what it goes to. So nice shot of it. Okay. Let's scan down the arm and watch that get smaller, 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 disappear. Go down a little bit further. Yeah, we've still got the biceps and brachialis muscle to the left of the screen. At the bottom here, we've got the triceps, but we don't see this muscle that runs across. Let's scan back up the arm one more time. Fantastic. And you can see the muscles inserting, kind of looks like the beak of a bird that goes into humerus. And this, we know the radial nerve must go above this, okay? The radial nerve, we're going to follow down a minute or two, but yeah, that's fantastic. That lets us know we're high enough in the axilla to even consider doing this block and making sure all the nerves are there. Okay.
So let's try and identify the individual nerves here. So they are all in the neurovascular bundle right next to the axillary artery and venous plexus here. So I can see at least 3 different nerve structures, and one of them is going to be median, one is ulnar, and one is radial. Median usually is the lateral leftmost nerve, and if I were to guess, that would be the median nerve. It's usually, you would see it either at 12 o'clock, or it could be anywhere from 12 o'clock to 9 o'clock to the artery. Ulnar nerve can be tucked in around 2 o'clock. It can be on the other side of the vein. So sometimes it's challenging to find, but in our model, it's very well evident. And then radial nerve can be anywhere from 4 o'clock to 6 o'clock position. One thing to notice here is right underneath the axillary artery, you will see a hyperechoic acoustic enhancement, and that is an artifact. So just seeing something bright there does not necessarily mean that the nerve resides there. It is just acoustic enhancement. The nerve could be there.
And we can see this when we do a femoral nerve block as well.
Right.
So you'll see something, we'll maybe look at that a little bit later. You'll see something bright behind the artery. So if you tilt the probe one way or the other, that'll often go. That lets you know that's an artifact rather than something that's actually there.
Yep. So if you were to do an axillary block, you would come from the left superior aspect, and that muscle right there is brachialis. I'm sorry, biceps and brachialis. And you will just head to 6 o'clock to the axillary artery. You want to make sure that you're avoiding any neural structures on your way. And as soon as you very carefully pop in right underneath the artery and you start injecting, if you're in the correct fascial plane, then you will see the local anesthetic spreading all around the vessel and going and surrounding all the nerves that are in relation to this artery. Occasionally, we have to go and take a second pass and go 12 o'clock to the artery and make sure we get a very nice spread all around the artery, and that is the goal. And if you do that, then you don't really need to look for individual nerves and get through the veins to get to those individual nerves, because this approach of doing 1 or 2 injections either at 6 o'clock or 6 o'clock and 12 o'clock will give you a reliable axillary brachial plexus block.
Yeah, so just come back to main
Yes.
camera, Monica. So when I do this, all I do is I put local behind the artery, put local in front, and I'm also going to look for the muscutaneous.
Yes.
And we'll look for that with Hannah. But what we're going to try and show is how do we know which nerve is which? And this is just a great teaching exercise. We're going to follow the individual nerves down to the elbow and back up so we can identify. I think the question was, how do you follow and know which nerve is which? So we'll start by we're going to put the pull back on the axilla, and then we're going to slide back in there and
let's look for musculocutaneous first.
Yeah, we'll look for muscutaneous first.
Okay.
Picture.
All right, so we're back in the same plane, and musculocutaneous is a nerve that you will find running, coursing. So you have to do a dynamic scan, and you will see it coursing in the fascial plane between biceps and the brachialis muscle. So I'm doing a dynamic scan up and down.
Scan distally, scan distally, scan distally, scan distally. Keep scanning, keep scanning.
It's right there.
Now we can see this top right where the arrow is. I'm shaking the arrow left hand side of the screen. If you scan up the arm, we can see that track back through the fascial plane. Okay.
Scanning up the arm now.
Scan down
now
the arm.
Scanning down the arm.
It's hers coming in low. And
yeah.
It's fascial plane. Look.
I see one right there.
And keep coming, keep coming.
Going down.
Yeah, keep going down.
I see another structure just taken off.
Yeah.
Right there.
Yeah.
Okay.
Keep coming down the arm. Keep coming down distal. Keep coming down distal.
Okay.
Keep coming down distal. Yeah. So I'm not sure if these are blood vessels coming off.
Yeah, there's some blood vessels as well. And
yeah.
Okay.
So now we're about halfway down the arm. It kind of looks like she's still got muscutaneous. It's really quite close. Yeah, it's interesting. So hers is not easy to see.
Yeah. Yeah.
I think you should check before you scan. So we'll look at the picture where the camera is. We're now almost all the way down to the elbow. So this is great. If we go down to the elbow, the artery's here. And there's one nerve with it.
Yep.
So what nerve stays with the artery all the way down?
That would be the median nerve.
Median nerve.
Yes.
So we know if we go down to the elbow, we can see the median nerve here. Okay. Now let's scan this back up. Okay.
All right.
And we can watch that position. We see it's like a 3 o'clock position beside the artery. Slide that into the middle a little bit. Well, that's great. Just keep there. Keep there. Now look, stop just there. Over here, coming from the right hand side. over the triceps, you're going to see something else slide into screen, okay? So keep scanning up, keep scanning up. So we've got one nerve here, we've got another, something coming in here, keep scanning up, keep scanning up.
So sorry, just need some gel here.
Yeah.
Okay.
Keep scanning up. So this, we can see coming here, this has come over the tricep. Let's follow this, two nerves close together. So this first one is now going up to 12 o'clock.
Yes.
The one taking position here. So let's scan back down that arm.
I think we need more gel.
Yeah, I need more gel.
Yeah.
Need more gel.
Okay.
I'm going to put lots of gel on here. Right, smear that about, yeah.
Okay. All right.
Right.
So back to the conjoined tendon. Okay.
Yeah.
Okay. That's the median nerve. We've confirmed that.
We think this one here we're going to follow now.
Okay. We're going to follow this one.
Keep coming, keep coming. Let's slide down the center a bit more.
Okay. There we go. Center.
Yeah.
Okay.
Yeah. So watching this. This is sliding away. This is the triceps muscle here. Keep going, keep going, keep going. Our median nerve is over here. And we have got, let's keep sliding, keep sliding, keep sliding. It's amazing to me how superficial sitting on the triceps. This is just adipose tissue and skin. Now it's protected because the inside of your arm, but heading all the way to the bottom of the humerus, we can follow the ulnar nerve all the way
and
down.
You can see it's medial humerus, medial arm, and that's your ulnar nerve right there.
Yeah. So
just...
let's follow that back up quickly.
Okay, so
let's scan
following
that.
the ulnar nerve back up really quickly.
It's so much easier to go quick once you follow it at one time. Okay. So stop just there, Monica.
Okay.
Go down a little bit.
All right.
Just scan a lot, slightly distal, and just stop there. So we have got our median nerve and ulnar nerve here. Down below, on the medial side of our arm, we have got the triceps. We've got medial and a lateral head and a long head of the triceps. And this groove here between the long and the medial head, if Monica scans down then up, we'll see the things traveling in this groove, okay? And this is the radial nerve. I said it needs to come out the spiral groove and then travel up to join the rest of the brachial plexus. So let's scan up, Monica.
Let's scan up. We're going to go back to where the conjoined tendon was. Here it is.
Yeah.
Okay.
And we're going to look for that radial nerve coming out. So let's scan down and let's look for that radial nerve ducking down. You can see materials here. Keep coming down. Yeah. Keep coming down. We can see
there. It's ducking down.
And that's going to dive into spiral groove.
And then it's going to emerge on the other side. So you can see it right there.
So why don't we go and look at the scan cam. I'm going to put on this. And Monica, take that down to the elbow. And let's just look on the elbow, on the lateral side of the elbow. This is going to track out on the lateral side. Let's look for the radial nerve down here. Have you got enough gel there?
Yeah.
So look where she's looking. We're looking at the humerus. A nice little trick is if you, when you actually get the elbow, if you feel the biceps tendon, let's put on this.
Okay, so here we have the ulnar nerve right there in the middle of the screen. I'm sorry, the radial nerve right there in the middle of the screen. And now we're going to go over to the elbow. And a good way of finding it is you can feel for the biceps tendon, which is right here. And you put the probe right lateral to the tendon. And it's going to be a very bright structure right there. In the middle of the screen. That's your radial nerve.
So if I feel the biceps tendon, if you feel the biceps tendon, if I go one finger breadth lateral, we'll find the radial nerve, and if I feel the biceps tendon and go one finger breadth medial, we'll find the median nerve.
That's correct.
So let's have a little look at Monica's. Actually got the probe there, and then we'll look at the ultrasound image.
Okay, so go back to the median nerve. So that's our radial nerve.
Yeah.
Okay.
Let's slide across.
And we're going to find the brachial artery.
And
just medial to that is your median nerve.
Yeah.
Right there.
So, do you want to relax the pressure there so you can see some veins? So, people are looking for veins at the rest of the median nerve is sitting underneath it. So, it's amazing. That's the first place we go hunting for needle sticks all the time. I'm amazed that we worry in regional anesthesia about nerve damage. And look, when people are sticking in peripheral IVs, how close the median nerve is to when we stick these peripheral IVs.
That explains the paresthesia people have, and they get IVs placed in their AC.
Yeah, they feel like shooting down, or you can see where that vein is right by the artery. So the vein and the artery and the nerve all tucked together here in the forearm. you can actually follow these down. It gets a little bit difficult sometimes find with the median nerve just to follow. I usually go
Okay.
to the middle of the forearm and,
All
and
right.
try and end up looking for these. If we just show,
Just get some extra gel here. Okay. All
so we're gonna,
right. So that's
we're gonna
radial right
slide
there.
that. Now let's look for the median nerve in the middle of the forearm.
Okay.
So we've got the scan cam on there,
So
and we'll look at the ultrasound.
that's in the middle of the screen as the median nerve, right next to the brachial artery.
Okay, and I'm
And
taking
has
that
to be
right
coming
away.
down the arm. It's
Ducking down.
ducking down.
Yep, fantastic. And it sits between the superficial and deep flexors in the forearm. And we've got the median nerve right here in the center of our screen.
Now we're at the middle of the forearm here.
Yep.
And yes, beautifully tucked in between the superficial and deep flexors.
Now, if you just pause there,
Okay.
and the arrow here is the median nerve. Over here is an artery.
Yeah.
And that artery is the
That's the ulnar artery.
ulnar artery. And right beside that
It's the ulnar nerve.
ulnar nerve. So we've got a lovely fascial plane here between the superficial and deep flexors of the forearm. Fascial plane here. And you can put local in the median nerve and put local in the ulnar nerve. But if you place your needle in the middle of this fascial plane, the local will spread to both. So this is I'm always looking for the cheat code, a way to make things a little bit simpler. And if I can do one injection rather than two, I always think that's better. And if I can put the local that will work in the nerve but not be close to the nerve, I always think that's a great technique as well. So we'll actually use this fascial plane right between the median and the ulnar nerve and place the local in there. In fact, Monica, we published in
Flexitorum.
the Journal of Clinical Anesthesia last year. We got a lovely anatomical description and showing where the local anesthetic spread with this. And it turns your forearm block into a two-arm technique. You can get the median, the ulnar with just one injection. You've still got to find the radial nerve, and we showed you how to find that. Find the tendon, and then just go one finger breath laterally to find that radial nerve. And actually here in our model, we can see two branches. If Monica follows those distally, you'll start to see them separate into superficial and deep.
Can you switch it to the screen there?
We'll
Yes.
switch to the ultrasound.
There we go.
Yeah.
So yeah, you can see the two branches of radial right there.
Two branches of the radial.
Centering that and
get your
following
eyes
that down.
nose, you're going to see them separate. One sliding off the left here, another sliding off the right. Try to trace that, trace that, trace that. It's a great game to play to follow smaller nerves and watch where you put the local. Now, when we work in an ambulatory surgery centre and people are coming in for operations, so often in a hand surgery, it's not just a hand surgery, we've got to consider the tourniquet as well.
That's correct.
And so that is why we end up doing blocks in the upper arm and infraclavicular region, is because we're trying to cover not only what's going on, but if you have a patient that's going to sleep, all I have to consider is post-op pain. So these are a great option to minimize the heavy arm that your patients will feel. So we're looking like for things that dissatisfiers patients don't like. They don't like pain. That's why we do peripheral nerve blocks.
Yeah.
But also they don't like that heavy feeling in the arm. And this lets you localize your local regional block to provide people with analgesia, minimize the nausea, get them home after the DK's upper limb surgery.
Do you want to talk about the cutaneous distribution and how important it is to plan?
Oh, yeah.
And so if you do an elbow block, you'll absolutely miss your medial cutaneous nerve of forearm, your musculocutaneous nerve, as well as those two major nerves will be blocked. So even if you did an elbow block, your forearm will not be anesthetized. So an elbow block may be okay for anything beyond the wrist, but not anything above the wrist.
Yeah, so if that surgical incision is extending up the arm, you got to be thinking to go along proximal. I think the only nerve that doesn't give off branches in the upper part of the arm is the ulnar. So already realize that median and the radial are branching off and sending branches. And you can even have T2 in some patients. That T2 we worry about in the axilla can, in some patients, the dermatome go all the way down the middle of the arm. So you can do a perfect brachial plexus block, and your occasional patient will still feel discomfort. And that's just due to anatomical variations in the distribution. Hopefully, we've covered now the radial. We've covered the median. Covered the ulnar nerve.
Yes.
I really like the axillary brachial plexus block, but since we're doing brachial plexus, should we in position? Should we stick with the upper limb? Should we maybe start from the top and look for interscaling, and then we'll work our way down. So let's move Hannah's arm by her side,
All right.
and Mo's arm by her side, and then we'll get some more gel
Okay.
and start looking.
Actually, there was a comment about intercostal brachial. Since we are there,
Oh, yes.
should we just go ahead and
fantastic.
finish that off,
Yeah.
and then we'll go up?
Yeah,
All right.
somebody here has asked can we see the intercostal brachial nerve, please? Okay.
So let's go ahead and put the arm back up. And intercostal brachial, it is the lateral cutaneous branch of T2 intercostal nerves. It's going to be coming out, arising somewhere in the middle of the mid-axillary line. So your probe needs to go right here, and it's going to be in a very superficial plane.
So that looks pretty posterior for the probe compared where normally, yeah, you're looking behind where you normally look for an axillary brachial plexus spot. Let's put the ultrasound on and put the picture up. So you're looking.
Oh, I think I have the probe reversed, sorry.
Oh,
okay.
So you're looking to, you're a little more deeper in the axilla there is where you're normally looking. Now, when I read the paper on this, they said they can find these nerves 50% of the time. And I must admit that when I look for these individual branches, I only see them 50% of the time. But I think my success rate at covering these nerves has improved because I place the local anesthetic just over the fascia that's lying over the tricep muscle here. So we're going to be looking in here for, as Monica's going to scan up and down, and I can see potentially individual sort of nerve branches going medial and lateral as she scans up and down. Looks a little branch here. This is another little nerve branch here. So what I would try and do is place my local anesthetic in this fascial plane. I like doing this with ultrasound because if you just slide back to the vein.
All right, sliding back to the vein.
It's amazing how superficial the vein is, okay? So I try and avoid these structures. The large nerves I've already blocked. Ultrasound helps me with that. And I can see little branches, little structures in the fascial nerve. And I'll just place a local anesthetic in this fascial plane here, lying over the muscle. And I think it's greatly improved the analgesia I provide doing that. You can try and trace that all the way back slowly, if you think to see it. See if these structures, if we go.
So I'm going proximal now.
Proximal, see if these structures go back towards the brachial plexus. And you'll often see these little nerves in this fascial plane working.
Because your medial cutaneous nerve of arm will be in that same fascial plane as well.
And so I'm not sure which one I'm blocking, but I found that placing the ultrasound to guide the local anesthetic in this fascial plane does two things. Avoids the vessels, avoids inadvertent puncture of the median nerve or the ulnar nerve, which are lying there, and also
highlighting very well now in the middle of the screen. Right there.
Okay, we can see just here.
Yeah.
Monica flips back and forward. We can see it.
So back and forth, right there.
Yeah, so again, she's hiding the axilla where we do this block. All we've done is really move the probe a little bit further around and back into and move the probe a little bit back around.
So I believe for these small nerves, a dynamic scan and going back and forth is very important because there's so many things that may look like nerves, but you want to see it being consistent and moving in a fascial plane.
And I found the color doesn't really help me in these tiny vessels. Often I put the color on. I don't see any flow. So I'm kind of discriminate a small nerve from a small vessel, and often I don't see any flow when I'm doing that. I tend to just like to see that move, and it looks for neural structures. Should we, when we're doing the upper limb, we'll get you positioned.
Okay.
And
I'm gonna put your arm back down here.
So I hope
we will cover you right here.
If you've had your event for the World Day.
Okay, so we're going to scan right here. I'm going to have you turn your head that way. Perfect.
It was the end of your day. I'm sure if you set up like us, you're tired. What we're going to do is carry on scanning here with the brachial plexus and do the interscaling. We'll look for smaller nerves, look in the suprascapular nerve coming off the brachial plexus when we do this, and look for all the nerve roots to track all the way back up. Again, I want to thank the organisers, Elena Moki, whose vision has set this up. Of course, we do these blocks to relieve people's pain and discomfort after surgery, to minimise the opioids they use, to help them get home safely to their families. And regional anaesthesia really makes more shoulder surgery here in the United States possible to do on a day case basis. People are either doing this with a little bit propofol sedation or combining it with a GA, whatever the patient wants or needs, and you can do this successfully. But one of the big debates for us as regional anesthesiologists is how do we minimize the side effects? And one of the problems of interscaling is you can get dyspnea and get breathlessness. So it's been a great move to move a little bit further down the plexus. So let's start by just looking at the probe in the neck
Okay.
and showing what we do the interscaling.
Okay, so traditionally interscaling landmark was posterior to the sternomastoid muscle, and then feeling for the anterior scalene muscle, and in the groove right here would be your interscalene brachial plexus. So I'm going to put my probe. Now with the ultrasound, you want to just start with your supraclavicular view, so you can get a feel for where the plexus is and try to trace it up. And that's now my go-to move to identify my brachial plexus. So what we're trying to find here is the first structure would be your subclavian artery, sitting right on top of the first rib. And that's right there in the middle of the screen. And then you see a whole bunch of bright structures, hypoechoic circles, layered posterolateral to the artery, and that is your brachial plexus.
So we've got, this is not rib we're on, but actually on
That's the rib right there.
right now we've got
Okay.
rib. And you
Now
go
we
a
got
little
rib.
bit higher for us. This is a bit more medial and higher. Not lateral, a bit more medial, up the plexus, Monica, just to the dome of the pleura.
Okay, that's pleura. I'm sorry.
Yeah, just go a little bit, yeah. So you're going a little bit higher. We've now got, if our model can take a big deep breath in.
Can you take a deep breath, Hannah? You're still seeing lung sliding here.
Yeah, we can still see some. So we've gone to that medial over the medial to the first rib into the dome of the pleura. If you scan down a little bit more, the plexus will come down a little bit lower. This changes into a more dense view, a little bit more. I'm going to increase the depth just a touch. I've got the. Okay.
Sorry.
We have got rib now, not sliding. You see a little shimmering pleura here to the left. It's amazing. In a young patient or model, when the bone is very dense, you get such a strong reflection. I often find it difficult to look at the artery just above it. So slide a little bit more medial.
Okay, slide medial.
Okay, so there's the artery here, the rib here, pleura sliding across here. And there's the artery, and here's the plexus behind. This is the origin of the middle scalene muscle. Okay,
yeah.
if Monica scans up, that will become more prominent. Middle scalene muscle, and here on this side, if she scans up a bit more, we'll see the anterior scalene muscle. Okay, anterior scalene, middle scalene, the plexus between. So let's scan back down again to that supraclavicular view, the artery. Okay. And the plexus here. So let's focus on the superficial part of the plexus, the bit closest to the skin. We'll keep our eyes on this. And I'm going to reduce.
Yeah, I think we have too much gain right now.
Yeah, I'm going to reduce a little bit of the gain a little bit. Okay.
All right, so.
And I'm going to reduce the depth a little bit as well. Because it's actually just so superficial.
Okay, so you're seeing some structures that tuck nicely in between those two muscles.
Yeah, this is middle scalene, anterior scalene, and our model is so slim that this is 1 centimeter here, so just millimeters beneath the skin, 1, 2, 3 circles. So the traffic lights.
Yep.
So we know that these 3 circles are usually C5, and C6 splits, becomes bifid or splits into 2. If we scan further up, these 2 will coalesce into one juicy nerve root, and this is going to keep going in and just stop there. You can now see
that's the
a
tubercle.
prominent anterior tubercle, Chassignac's tubercle at C6. Keep going, stop again, prominent anterior tubercle, keep going, keep going, keep going. There's the nerve root. And the nerve root is disappearing inside. If you scan down again, Monica, C6 comes out, it splits into 2, and it's got C5 here at the top. So let's now concentrate on this one, the top of the traffic light. And Monica, scan up the neck slowly. Slowly, slowly, keep coming up, keep coming
I'm
up.
sorry, I'm going down, up,
Yeah, up the neck, keep
coming
coming
up,
up,
coming up.
keep coming up, keep coming up. C5, C5 here. And this C5 is going in front of the anterior scalene. C5 is still here. C5 is here. C5 is here. Then it's coming back into the groove. Stop just there, Monica. And that's C5 there going in. So C5 is coming in. Now, we're pretty high here. If we look between the sternocleidomastoid, which is up here, or the remnants in the middle scalene, and this fascial plane, when Monica scans down and scans up, we'll see some little black circles in this. This is a superficial cervical plexus. We'll be sliding through this fascial plane. Okay.
So just scanning up and down.
Yeah, look, just here. Just what, here? It's,
Yeah, you can
as
see.
you scan backwards and forwards, we can see the superficial cervical plexus.
And that's, you can almost see the C4 going down now into the,
Yeah.
that's C4.
Yeah.
That's
C4,
going down into the
into C4
your
nerve.
foramen,
Let's come
yes.
back up.
Okay.
Back down. C4 coming out, and then you can see the nerves here. If you go down, keep going down.
And there it is.
So if you want to do a superficial or deep cervical plexus block, and somebody here asked for, a little bit earlier on, Sandra Q asked for the superficial deep cervical plexus block. You can see how superficial this is and how easy it is to do cervical plexus blocks with ultrasound.
So do you want to talk about the differences between superficial and intermediate and deep cervical plexus block?
Yeah, when I was a boy, there was a superficial deep cervical plexus block. That was it. When I've got a superficial intermediate and deep cervical plexus block, are we making this easier or are we making it more complicated? The patients haven't changed. Our descriptions of the things have changed. So I think a superficial cervical plexus block, I think of a landmark technique where I'd get the midpoint of the sternocleidomastoid and just put local anesthetic in behind that, spread up and down in a kind of sausage shape. I now do this with ultrasound, and I put local anesthetic in the fascial plane there, at the posterior edges. Now, what's a deep cervical plexus block is to go right down onto those bony roots, and Monica showed it's lovely that you could scan to the bony C4, and you can put the let's have a little look just now.
Yeah, so just to add to that, yes, so let's go back to where C4 is. So I'm going to go back to the interscalene view one more time so we know where the nerves are.
6, 5.
Okay, now I'm going up. That's 5. Okay.
5.
Should we reduce the gain? Maybe. Yeah. Okay, that's 5.
Yep.
Going down into the canal.
Yeah.
Right there. That's 5.
There.
Okay.
Yep. And then we can actually see the nerves here from 4 just together and coming up a little bit more, Monica.
I'm going up. And there it is. You can see a nerve-like structure diving into the canal.
Yep.
But at the same time, I debate about the utility of deep cervical plexus when you can get such a nice spread with an intermediate. There are studies that have shown that if you inject in the fascial plane behind the sternomastoid muscle, do you really need to go so deep? And
so if you in this fascial plane here, if you go a little bit deeper here, when you actually look at a cadaver and you put a small amount of dye, it goes everywhere, doesn't it?
It goes everywhere. When we injected 10 mLs, it spread to a lot of critical structures around around that area, including phrenic nerve, vagus nerve. The question is, do you really need to go there?
So cadaveric dissection has got so many uses. It's taught me to use a lot less local anesthetic when I do a cervical plexus block, because we had it spreading certainly to the phrenic, spreading
to vagus,
spreading to other cranial nerves as well. So small volume goes a long way when you do this. And if you're doing this for carotid artery surgery, it's easy for the surgeon to supplement and put a little bit more local in as they go down.
So I would stick with the intermediate and go behind the fascial plane of sternomastoid.
I don't think there's any need to go right down. And somebody here put a comment. they said vertebral artery. Yeah, vertebral artery is there.
Yes.
And you'll get like cervical epidural spread as well. So
And
GM TOF, yeah, you know, we'll look a little bit lower down for the vertebral artery, maybe turn that probe around in a second and show you around C7. We'll often see that artery sit at C7. But, you know, there's a lot of structures down there that I think we really need to be concerned with. And I'm along with Monica. I now just do a superficial cervical plexus block, but maybe I do a slightly deep superficial cervical plexus block. And I found this is adequate for our surgeons to work with, and you know, talk with them and discuss if you need to put a little bit more local anaesthetic. Certainly when they get down to the vessels, a little bit local around there, stops those changes in heart rate, blood pressure. You'll see with this surgeon actually putting that around the carotid body.
yeah, I like to call neck prime real estate. And there's too many important things going up and down, and we have to have a huge amount of respect for each of those structures. So just stay very respectful to each of those structures, and you'll be fine.
So let's slide back to the brachial plexus. We ended up starting here going to show we're going to do interscaling, traditional interscaling, and lying on the anterior phrenic and very close to the plexus, as well as having, you know, us getting the brachial plexus. The local anaesthetic is going to spread, and the local anaesthetic is going to spread there, and it's going to end up getting close to the phrenic nerve, which is, you can obviously lying on the anterior scaling muscle. We'll take this arrow out of the way just now, and Monica just gets oriented with scanning on the picture view. So you can see
back to
the probe moving and also see that sync with ultrasound. That's a lovely picture, Monica. We see those traffic lights at the top and the center of the screen. Really looks fantastic there. Okay, now interscaling blocks over 100 years old. It's what we will use for this. It's one injection. One injection gets the brachial plexus and also gets the superficial cervical plexus. So when the surgeon puts the needle through the skin, it's going to be easier for the patient. I mean, you do this for wide awake surgery. You've still got to supplement T2. T2 is never in the brachial plexus. So some infiltration in the armpit is often necessary for awake shoulder surgery. I've also sometimes done a T2 paravertebral nerve block. If this is going to be a big surgery, sit the patient up, do a quick T2 PVB, lay them down and do the interscaling. So the interscaling one block gets it all, and we want the local to spread sometimes, but in some patients, you know, we don't necessarily want those side effects. We don't want the Horner syndrome, the droopy eye. We don't want the patient breathless. So there's been a real move to move further down. And I think when Alan Winnie described the interscaling block, he had to use landmarks, and he used the level of the cricoid cartilage, because that's something as anesthesiologists know all about. You know, we can see that, we can feel that, and that's a nice standardized approach. But now with ultrasound, we can go lower. And there was a fantastic paper out recently that said the supraclavicular nerve block is just as good as the interscaling.
Yes.
So let's scan down from our interscaling view, okay?
Before we scan down, can we point to two of structures in the middle scalene muscle?
Yeah, look at
Okay, so you can see there's two nerve-like structures in the middle scalene muscle above, further above, I would say, right there.
You scan.
Right there. That is the dorsal scapular nerve. And there's a very nice paper that came out of Virginia Mason. Dr. Young published a study where they were able to map out these two structures. So there is the dorsal scapular nerve as well as the long thoracic nerve, which would be a little more medial to it at the bottom, right there, right there.
Here,
so those two nerves are very important to trace out. So whenever you're approaching the interscalene brachial plexus, it's super important that you avoid these nerves that are in the way.
Yeah, can I, if we put this just in the center screen here, Monica?
Sure, yes.
Put the plexus right in the middle, okay? I will actually bring my needle in the subcutaneous tissue and then just poke it through here. To help me do that, I'll actually, I'll do quite a heel toe. If you tilt the probe anterior.
Yes.
Yeah. As Monica tilts the probe, you see the plexus start to look like it's tilted to the side, doesn't it? And this makes
Yeah.
the needle coming in and easy to slide the probe down. So if you look at the small pitch at the top, if you, Monica, if you turn that, slide the pressing the heel and then pressing the toe, just to show people that
So
motion.
that's
In fact, I'll go to
heel.
camera one. That's
Sorry.
heel, and then shows
That's
the
heel,
toe,
and that's toe.
and that's toe. And what happens, now we'll put on camera two, do heel, pressing the
Heel.
heel, it
It's
straightens
straight.
the plexus out, pressing the toe.
Toe.
And when you get the plexus in a tilt, it's really easy to slide the needle in just here. So I'll stay superficial to the middle scaling and then just pop down and place my needle just so superficial just behind it. Let the local stay in there. You don't need to move. I don't want to separate. I never put local in here between C5 and 6. And look at this beautifully C7 sitting here as well. But I'll place a local here and let the local do the work. One of the dangers we get is going too close when we do ultrasound guided regional anesthesia. So I want my needle here, want the local spread down behind. Don't be worried that there's no local in front of the brachial plexus. The block will work perfectly well with the local just behind. So I always think it looks like we get hurricanes here in North Carolina. Normally the traffic lights hang vertical, and in a hurricane, the wind blows them and they hang to the side. So I look for the sign. I look like it's a North Carolina stoplight in a hurricane. It's leaning over to the side, and that lets you slide your needle in easily and hopefully avoid those two nerves.
Yeah.
So let's put this back in the center again, Monica,
Okay.
and we'll start to just slowly scan down. Okay, we've got C7 here. Okay, let's follow C7 all the way down, and C7 comes down, and we just stop. We can see C7. There's a posterior tubercle. There's no anterior tubercle. It kind of looks like me relaxing in a lawn chair, falling asleep in the afternoon there. Okay, C7 is going to go into that nerve root. Lying in front of here will be the vertebral artery. If we actually try and put some color on, and we can see that this is quite juicy. Okay, there is no protection this little bit lower from that vertebral artery. Okay, so this is the level and line a little bit more anterior here if you're going to do a stellate ganglion block. And look, another transverse cervical artery coming across the top.
Right.
And this that appeared just in time, because we're talking about going lower and doing different approaches to the brachial plexus. Why don't you slide back up there for me, Monica, here. Upper root, C7. If you want to do a superior trunk block, you're going to do this as this looks more circular rather than traffic lights. Keep coming down low, keep coming down low, keep coming down low, keep coming down low. And now I've got a blood vessel above, just where I want to do my superior trunk block. And if I look across, go lower, I'm going to see that her coming off the right.
And there's another vessel, that's
There's
suprascapular.
another blood vessel, suprascapular vessel, and it looks at this as the suprascapular nerve.
That's going to go down
keep
with
going
it.
further down, keep going further down, keep going further down. Suprascapular nerve here with the artery.
Yeah,
It's coming
and
off.
it's kind of
Yeah.
hard to go
Yeah.
trace
We
it
can't go a little bit
beyond.
further. We can try
Yeah.
trace it back up.
All right.
So we come a little bit up, a little bit up, a little bit up, a little bit up, further up, further up, further up.
There it
Stop
is.
here. There's a superior trunk. But we've got the superior trunk, but we've got a blood vessel above it. We saw another, the middle scalene, another blood vessel
There, right
just
there.
below it. It's a very narrow window, I oftentimes. So I'd love to do the superior trunk block a lot of the time to go a little bit more distal. And I found this description sounds great, but a lot of time it's exactly where these blood vessels are lying that makes this superior trunk option tricky.
Yeah.
So
So it's going back and forth here. That's the transverse cervical right there up top. You're going to put some color and we can show
we'll
it to
put
our
the
viewers
colour
here.
on,
That's the transverse cervical. And
Yeah.
going down further, that's the
bit further.
suprascapular.
the suprascapular artery just beneath
Right
it.
there.
So I often end up doing supraclavicular nerve block or going even more distal. So we're going to work our way down. We'll take the colour, we'll go back,
Okay.
colour off,
Okay.
and we'll follow that plexus a little bit further down, okay? There we are
Alright,
here.
there we are.
Now,
Mm-hmm.
the suprascapular nerve has appeared.
Yep, it's
right
gone.
here, okay?
It's gone.
It's now left the brachial plexus. But if you do a supraclavicular nerve block, the local tends to track back up the neck. Tends to track back up the neck, and you will get that suprascapular nerve.
Yeah.
So there isn't any right way or wrong way. And don't get me wrong, we've got a whole palette with which to work here. If we get used to scanning up and down the neck, anywhere is the right way to go, the right place to go with the right volume of local anaesthetic, and you can achieve adequate shoulder analgesia from supraclavicular, if you want to call it superior trunk, or a classic interscalene, and you can adjust the volume of the local anaesthetic you use, and you can adjust the amount of spread you will get. But in all of these, you'll get very good pain control for post-op after shoulder surgeries. So we are always doing this dynamic scan, putting on the colour, makes things look a lot more obvious. We can see where there's blood vessels there. We're going to make sure we do not harm that patient and manage to avoid some of the blood vessels.
Yeah.
So wherever you get a nice trace for your needle to come in, I'd say is the right place to do this, and you're trying to think. And sometimes I go out to do an upper limb surgery and I'm going to start with supraclavicular nerve block and there's blood vessels overlying, and I can't do that, and I'll switch to infraclavicular. But let's just follow that suprascapular nerve out and back, and we're down here. We can see it here. To turn the probe around a little bit, Monica. Yes,
That's right there.
Now, suprascapular nerve is really important for soldier surgery, C5 and 6. The other nerves are the axillary nerve and the nerve to subscapular. The suprascapular nerve, the axillary nerve is going to abduct the arm, and the nerve to subscapularis. So 3 main nerves along with are going to supply the shoulder. By doing a supraclavicular nerve block, we know that the nerve to the nerve roots for the subscap are C5 and 6. We know that the nerve roots, the axillary nerve root, are C5 and 6.
And the subscapular.
And the subscap, suprascapular, and axillary nerve, all C5 and 6. So those traffic lights, that serior part of the brachial plexus, you know, the local will track back up the nerve to get that suprascapular nerve. It has separated. So that's why a supraclavicular nerve block works if we target that superficial part of the brachial plexus. Now, if I'm going to do a supraclavicular nerve block for regional anesthesia, I put local down at the bottom to make sure I get C8 and T1.
Yes.
If I'm doing that supraclavicular approach just for shoulder surgery, well, in those cases, I really just focus on the upper part of the brachial plexus. I don't bother with that lower injection. I really want just C5 and 6. So the superior trunk. You can start to see those trunks and divisions starting to separate as you scan down, and we can see some splitting of that trunk. We'll see if Monica can follow that just now. As we go down that start, we can see if that plexus starts to separate.
Let me get some more gel here.
Yep. Put some picture on. And Christine Yo, thanks for tuning in. Sandra O, Eslam, GM Toff, Ezra Europe saying hi from Paris. And thank you. Well, no thank you to Ezra
thank
Europe
you.
for again everything organized.
Thank you
for this
all.
World Day of Regional Anesthesia.
We're incredibly thankful to all of you for joining us for this common cause and celebration.
So as we come down, we start to see this spread out, yes?
Yeah.
And interesting, when we hit this posterior part, super part of the plexus, these are the parts that go on to actually innervate the shoulder joint. We can see the divisions start to split here. So bunch together, let's come down, superior trunk, and we can see that starting to split into anterior and posterior division. So we place a local back here. Yes, we're going to watch the blood vessel, but we stay superficial. We can get the parts for supply of brachial plexus.
Right.
Should we? We've done a lot here. We're almost at 50 minutes.
Oh, yeah.
So let's maybe go to just with the brachial plexus. Let's scan down and look at the infraclavicular. Because we've had some new changes in that, and try and scan that from lateral to medial infraclavicular region and look at some of those.
Okay, so what I'm scanning here is feeling for the clavicle, which is right here. And there are 2 approaches to infraclavicular brachial plexus now. One is the costoclavicular and one is the lateral sagittal approach. So this is where we found the artery. So I'm going to go right under the clavicle, right at that level, and look up. So we're almost looking at a mirror image. Can you give me some more depth, please? mirror image of the supraclavicular brachial plexus, except that now you're looking underneath the clavicle, and I can see some really big blood vessels here, which seems like that's the subclavian vein, and there's a cephalic vein draining
Yeah, it's kind of
into
like the tadpole sign, somebody
right
called it.
there.
Smell like a tadpole.
It is.
And the artery is here.
Yeah. So,
So yeah, axillary vein, I think looking wanted to be cannulated. I've only had a needle right now, but our model didn't agree to that. But it's certainly for central venous access, nice approach here. But you can just see how close the artery is. And wow, in looking at this is really 1, 2, 3 stacked up.
and there's a vessel in between.
A little blood vessel tucked in between, of course.
Yeah.
But let's talk about first muscle here at the
so
top.
that would be the pec major, clavicular head of the pec major, and then followed by subclavius.
Yep.
Yep.
And then we can see 1, 2, 3 nerves stacked together.
So usually the most superficial one is the lateral cord, and then the one posterior on the side would be the posterior cord, and then inframedial would be the medial cord. And there's descriptions of there's a septum usually lying between the lateral cord and the posterior and medial cord being together. And there talks about approaching. So I'm quite lateral here on our model, and I'm having trouble.
Down here is the
I'm going to have Hannah abduct her arm, and in fact that may open up. There we go. That made a huge difference. Can you see when our model abducted the arm, we suddenly got a lot of space in between to maneuver our probe.
And more importantly, for somebody doing the nerve block, on the right hand side of the screen, we've got room to watch our needle advance. So the arm is abducted to the camera shot in the corner. The arm's abducted to 90 degrees. Okay, just the same position we'd have it for somebody doing an axillary brachial plexus block, and that's given us room. It's moved the clavicle up and out the way. We've now got room to approach with our needle. Okay.
So there's two approaches that are described. Coming in between the lateral cord and posterior cord and injecting there. But you have to be careful. You have to make sure that the local anesthetic is spreading both at the level of the lateral cord as well as the posterior cord. There being a septum, in almost 2/3 of cases, lateral cord is separated from posterior and medial cord with the septum. So there are some other approaches where they're looking at 2 injections, one going between posterior and lateral cord, and then one separately going for the medial cord. 2 injections certainly decreases the onset time. However, the one injection also sets up within 30 minutes completely.
And you want to slowly scan lateral here, Monica?
Okay.
If there's enough gel, we'll slide lateral. Oh, yeah. Trying to get that. Keep it in the center of the screen. Yeah. Keep going lateral. Keep going lateral. And as we go lateral, you see there's a little bit more room to come in with a flat approach. Yeah.
Yeah.
And possibly room to slide underneath and avoid the plexus and then pull a little bit more. We're trying to avoid the actual nerve structures and slide the local anesthetic into those individual fascial planes. When you do any of these blocks, when you put the first cc or 2 of local anesthetic in, the image looks so much easier to identify. Put the first bit of local anesthetic in. So the local gives you a great contrast between the nerves, and often find that subsequent injection where I want to put it between planes so much easier after putting the first few cc's of local anesthetic.
Right. Stu, can you lower the depth and we can show the pleura here to our viewers?
Yeah.
So you can see the costoclavicular block. The pleura is very close. And there have been instances of pleural puncture and pneumothorax reported after this block. So this would be considered a block that should be done by somebody who has demonstrated a good needling skill and has seen the needle tip at all times, because you can see pleura is very close and you do not have the first rib just like you have with the supraclavicular brachial plexus to prevent you from getting into the pleura.
And there's the shadow of the clavicle.
That's the clavicle right there.
Yep.
Yes.
Okay. So do you want to go a little more lateral into like a traditional infraclavicular
Sure.
plexus?
So
show
we'll do the camera here. So for landmarks, you want to go at the lateral edge of the clavicle and feel for the coracoid right there. Arm should be abducted 90 degrees, so you have room. And now I'm going to put my probe sagittally. So right below the coracoid process. And you want to see these two muscular structures. There's the pec major right where the yellow arrow is, and then the pec minor right underneath that. And now we're going to look for some blood vessels. So that is most likely the axillary vein, and then to the left of that would be the axillary artery. And you will be coming from the top of the screen. So that's superior, approaching superior to inferior. So your goal here is to maneuver your needle tip and try to get to 6 o'clock to the artery, just like we talked about with the axillary brachial plexus block, this being a neurovascular bundle. And in our model here, it's very easy to look at the nerve roots. And if I let off the pressure, you can see there's several vessels in this area. So you have to be very, very careful maneuvering around those blood vessels. But the goal here is to get, avoiding these neural structures and get underneath at 6 o'clock position to the axillary artery right there.
Axillary artery pulsating here.
That's the vein, and that's the axillary artery right there pulsating in the middle.
And often I put the color where our needle is going to travel. It's often very obvious, the artery. What I want to do is put the color box up here to see if there's other small vessels on the way that I need to avoid. So that is, yeah.
And when you do an infraclavicular brachial plexus block, both of these approaches will give you majority of the shoulder joint again. Now you will miss the suprascapular nerve. However, all the other nerves, so contributions that are coming out of the posterior cord, the axillary nerve, the subscapular nerve, and contributions that are coming out of the lateral cord, which is the lateral pectoral nerve, they will all be going to the shoulder, and they will all be blocked with this block.
Yeah, so somebody asked where's the nerve to subscap. It comes off the posterior cord, and if I am trying to do a phrenic sparing shoulder block, I will block the posterior trunk, infraclavicular, do an infraclavicular brachial plexus block, really aiming to the posterior trunk, because that is where the nerve to subscap comes off. Can I follow the nerve to subscap? No, I am not that good. I haven't seen these describing or showing the nerve to subscap. I can show you something and tell you it's the nerve to subscap, but I think I would really be lying if I said that was actually the nerve to subscap. But we know it comes off the posterior cord of the brachial plexus. We know it's important to get the complete shoulder analgesia. So if you want to do a block that spares the phrenic, I would do a posterior suprascapular nerve block, put that under the muscle there on the scapula, and then combine that with infraclavicular brachial plexus block, and you can get great shoulder analgesia without avoiding the phrenic nerve, the problems you may have with it. Monica, we kind of talked about infraclavicular, but really focused on upper limb. One of the things that we end up using ultrasound for, nerve blocks, but one of the things we're now using a lot of POCUS, and what I thought that we could do is maybe a little bonus before we finish at the end. We've got somebody here who has helped us out by not having breakfast. We're going to scan an empty stomach if folks want to see that, and then going to give them a drink of some soda, and let's see if we can see the stomach filling up. Joseph, I know now in America that GLP-1 drugs are a big thing, semaglutide. We've got a lot of patients arriving with full stomachs. We're looking at how do we look at fasting. So we'll have a little look at that later before we finish. I thought now we've gone on talking from upper limb. Maybe we can, one of the first requests that came in, and thank you very much, was to show pain and lateral femoral cutaneous nerve block. And Monica here is the best person to show that. Monica just published a letter and wrap them showing cadaveric dissections of when you put your needle in for a pen block, with a very high chance it'll actually go through the lateral femoral cutaneous nerve. So we will maybe do fascia iliaca, pen, and lateral femoral cutaneous nerve block. So as we are getting our model organized and positioned, we're really looking at options here for hip fracture patients. I think that there was a Cochrane review, and I love the language. It said, enough already. We don't need any more studies to show us that peripheral nerve blocks are really important for hip fracture. They improve the pain, they reduce the pain and discomfort for this vulnerable patient population, for elderly patients. We have tried to push this and successfully push this out with our colleagues in the ED. And we're doing blocks on these patients as soon as they arrive in the emergency department. Allows us to control the pain earlier. But yeah, we're going to start looking for lateral percutaneous nerve and pain block.
Curvilinear probe.
We're going to use a curvilinear probe. Okay, so
Switch.
So we're just going to change over to a right probe to do this. We are doing a mixture of suprainguinal fascia iliaca block and pain blocks for hip fracture patients. And some of our colleagues don't feel happy doing that, and they will just do a femoral nerve block, which provides great analgesia for a lot of these hip fracture patients. So it's whatever you have got the skill and whatever you feel comfortable doing. So maybe we'll start going over here and showing you on the camera where our ultrasound probe is.
Okay, so I'm feeling for the anterior superior iliac spine, which is right here. Okay, that's the anterior superior iliac spine. This is lateral, that's medial. Okay, and now I'm putting the probe right here on the groin crease, right on top of the inguinal ligament. And we probably need more depth. Let's see. Okay, yeah, okay, so what you're looking here, that's the hip joint. And our goal is to go medial.
So just shows that bone again, just a little bit.
Yeah,
Arrow, just make sure
the
we
hip
can
joint.
see the hip joint, and we can actually see a little bit fluid in the hip joint here. Fantastic. So
okay, so going a little more medial here.
Picture for folks who can see what the probe is. Okay.
Okay, so our landmarks here that we want to look at would be the pelvic brim. Which is coming in the picture.
Yeah.
So that's the hip joint right there. And if I go just a little north of that, that's your pelvic brim. Okay. And then just lateral to that is the anterior inferior iliac spine right there. And I guess we can reduce the depth now that we have found our structures. And let's identify the structures in the screen right now. So the bright white line at the bottom, that's the pelvic brim. The muscle that's laying on top of that, laterally is, it's a combination of two muscles. There's the iliacus along with the psoas tendon. And psoas tendon usually is a fibrous structure you see kind of tucked at the bottom. And it's more fibrous in more elderly patients. In our young model here, you can see it's almost a circular tendinous structure. So I'm going back to where I'm seeing the anterior inferior iliac spine. So the goal with the PENG block is when you bring your needle tip, you're going to come and hit the pelvic brim. So come from lateral and come and touch the pelvic brim right there. Most important thing being you want to make sure that you have come out of that psoas tendon, because that tendon will prevent the needle tip from going out just because it is so fibrous and you have a bony backstop. So sometimes you have to really twist your needle out to really make sure that you're layering nicely around or inferior to that tendon. If you're in the tendon, you will feel very high injection pressures. And that means that you are still injecting in the tendon, and that's going to give you a fail block. Not only that, it will also give you leg weakness because of injection into the muscle. So it's very important to make sure that you're layering nicely underneath that tendon, and that you have come out of that tendon. We frequently encounter going into the tendon, and sometimes if you're having a hard time coming out of that, you can just approach it a little more laterally and inject right there. But you want to see a nice layering happening underneath there. In addition, so you want to inject 15 to 20 mLs. That's plenty. You know, the goal for this block is to be motor sparing, and you can see, you know, you can see pulsating vessels here. There's a femoral artery there, and the femoral nerve is pretty close to that. And if you inject a large volume, be more than 15 to 20 mLs, it will go around the psoas tendon and get into the femoral nerve. So your goal of keeping this a motor sparing block is not going to be met. So 15 to 20 mLs is good enough. But what we also showed was, in addition to PENG block, where most of these surgeries are involve an approach from the lateral hip, and joining or using an additional lateral femoral cutaneous block with this block will also give you incisional pain coverage. So what we showed in our study was, you can see the sartorius muscle right here, and the LFCN, or lateral femoral cutaneous nerve, has a very close relationship to the I'm sorry, has to the fascia iliaca, which is right here. So what we could do is, first you inject here deep, 15 to 20 mLs. On the way out, you just stop right here at the level of fascia iliaca. At this level, your lateral femoral cutaneous nerve, in fact, travels superior or more superficial to the sartorius muscle. So if you just stop short at just superficial to sartorius muscle and inject 5 to 10 mLs there, you're going to have a very nice LFCN block. So you can use these two blocks, do these two blocks with one single trajectory. At the same time, you know, making sure that patient doesn't have paresthesia going in, because you don't want to go through the LFCN nerve also. So just be very watchful of that. It's not a motor nerve, it's a sensory nerve. So if you go through the nerve fibers, the patient may experience paresthesia. So caution, but at the same time, use it to your benefit for doing single injection, single approach to injections.
Yeah, and it's you know, great when teaching our residents how to do this. Another great one is just if you really are a beginner, is just to do a femoral. Do you want to switch back to a linear probe?
Yes.
And show folks? And if we have that linear probe, but a higher resolution probe, we'll also be able to slide lateral, maybe show you the lateral femoral cutaneous nerve that slides over the sartorius.
Yes.
When we did this in the cadavers, and we injected in cadavers, if we didn't get deep to the psoas tendon, the local tract up the psoas muscle often involved the femoral nerve block. So there have been reports of this supposed to be a motor sparing block. If it's done ideally, fine, but awful lot of elderly patients, it's difficult to get deep to that psoas tendon. If you don't, then the local tends to track back up the psoas muscle and ends up get a femoral nerve block as well. So watch the volume you use, watch the concentration, because it is just an analgesic block, and also make sure you're definitely deep to that psoas tendon. Okay, so we are now going to switch over back to the scan cam, and we're in the groin here, and we're going to be looking for the femoral artery and the femoral nerve. Okay, so we'll put on the picture view.
So
and Monica's got the
femoral artery, femoral nerve, iliacus muscle, and fascia iliaca right there.
So if you trace that fascia iliaca laterally, maybe square the problem a little more so you know exactly. Here we've got sartorius muscle, okay? And further out, it's going to be tensor fasciae latae. Really superficial. I'm going to reduce the depth even more. And we scan down the leg between these two, and I'll find an arrow again. Tucked in here, we're going to look for branches.
Oh, it's right there.
Sliding over the fascia.
Yeah.
Keep coming down the leg, keep coming down the leg, keep coming down the leg.
Yeah.
Yeah, a little fat pad. And you can get 1 to 4 branches of the lateral femoral cutaneous nerve. So tensor fasciae latae, the lateral edge of sartorius, keep coming down the leg, keep coming down the leg. And often it's easier the further down you go, these little fat pads start to separate. And if we, I'll increase the depth slightly for us here, okay, and let's go back up the leg, looking at
or up here.
yeah.
And there it is. You can see
See
those
little
little dots in the dark circle.
And if you find one branch and block it, you can't be guaranteed you've got it all. As the Monica scans back up the leg, we can see those little dark circles now following back up.
And you can see how reliably now they have crossed over to the anterior surface of the sartorius muscle. As the sartorius is getting more tendinous as it comes to approach the anterior superior iliac spine, your LFCN is going to be sitting right on top of the sartorius muscle.
Keep it up. Anterior superior iliac spine, the bony points here. And then your sartorius ends up being under the iliacus muscle. And above the inguinal ligament, the lateral femorocutaneous nerve is going to be underneath the fascia iliaca. I can almost think we can see the nerve right tucked in right here. So let's come back down and show people the femoral nerve block, Monica, again.
Yes.
Okay. Because when we use the terms fascia iliaca and femoral nerve block, a bit more medial.
All right, so back to your blood vessel here.
Yeah, blood vessel right in here. Femoral nerve, this is the iliacus muscle, sartorius above it. This is an infrainguinal iliacus block, whilst if you slide, careful, Monica, for us, keep going up. Sartorius disappears. We've still got the iliacus muscle, and we slide all the way up to ASIS, and just above it, we are now doing a suprainguinal fascia iliaca block. The reason we put a large volume with a femoral nerve block is we want local anesthetic to spread to the lateral femorocutaneous. And it will spread underneath the fascia iliaca from the femoral nerve and get the lateral femorocutaneous nerve. And you slide medial and down. So next time you do a femoral nerve block, if you slide a bit more medial for me, Monica, and you can see the femoral nerve here, follow your local anesthetic out and you'll see it spread the lateral femorocutaneous nerve. Okay.
Yep.
And you end up blocking both. And all of these will give you analgesia for patients with a hip fracture.
Yes, yeah. And any block, there's so many blocks that are now described in the literature, and there are small-scale studies that have shown benefits of each of these blocks. Peng block, some very new studies came out 2023 and early 2024 showing Peng as being a very promising motor-sparing block and helping with hip arthroplasties, hip arthroscopies, even some high intertrochanteric fractures.
Hip arthroscopy, when I see that in ambulatory cases, as much as I love regional anesthesia, sometimes I'm a little bit apprehensive. I've had a lot of patients from the stretch, from the hip arthroscopy, they end up with a neuropraxia and either a foot drop or sometimes even have some femoral nerve partial palsy from that. So that's a difficult one for me in ambulatory surgery. I love to hear people's comments on what they do for hip arthroscopy, because I've got a worry about the worry about the pain on a day case basis, but I also got a worry about that neuropraxia that can be caused by the surgery and putting the patient on the rack and stretching them out. I wonder if anybody's got a great solution for that. Somebody's asked, can we do obturator? Well, to spare our models blushes, no, we're not. But if you want to see an obturator nerve block, please come along to the ARJA Pain Medicine Spring Meeting. We're going to be in San Diego this year. Looking forward to Ki Jinchin. Has got a fantastic program. That's coming up soon. You go to ARJA Pain Medicine's website and you can sign up for the ARJA Spring Meeting if you want to see some blocks like that. A much more personal and quiet setting where we can happily show you things like subpectineous obturator nerve block. You can see that there. Another place I'm going to go and lecture at the RE UK meeting in London. Sign up for that. And there's great workshops there. You can see these sort of things done in that sort of setting. So we did have a request for to go a little bit further on the leg and to show us, distal femoral nerve blocks. Let's get in the mid thigh. Let's look for follow that sartorius muscle down to the middle of the thigh and find the blood vessels, Monica. And let's have a.
I'm gonna have you bend your knee. And
We'll
bring
have a
it out
look
like
and
this.
let's find sort of the mid-femoral or femoral triangle or adductor canal block. Okay, there's a whole lot of gel.
Okay, so we have our model frog legs, so knee flexed and rotated outside.
Okay, so
Okay.
the thigh and the frog leg position.
Okay, and you're gonna feel for the mid thigh. I'm gonna have a little higher depth here. You're gonna put the probe right on top of where you believe your sartorius muscle is. You can see the femur, so I'm just gonna go back and forth. That seems to be the vastus medialis muscle. And I'm gonna flip the probe so it makes more sense to me, I'm sorry. Okay, coming up here. Vastus intermedius.
Okay.
So going to the right. So vastus intermedius and rectus femoris. So we're like right in the middle of the leg here. So that's your vastus medialis.
Okay.
This is going a little more medial. And that's the sartorius muscle right there. Okay.
So in older patients where the muscle definition isn't as good, Monica, my first landmark is I use scan medially. I scan lateral to medial, and I use the artery as my first landmark because that really does help me identify the sartorius. And if you're beginning and doing this block, one of the tips is to make sure you're proximal enough in the thigh. If Monica sort of smears the gel first and then walks down the leg, you'll see that this muscle is going to sort of be separated from the artery when Monica scans down the leg.
Okay. Get the arrow.
Right.
Okay.
There's the artery, there's the
artery,
muscle.
that's the muscle.
And if you scan down for us, Monica, while the artery's ducking down into the adductor canal or Hunter's canal, let's scan back up. There. And there's sartorius muscle there. And there's our artery. And
That's it.
what we got? Is this the lateral side here, Monica?
Lateral side is towards you, yes.
Yeah. So it's sitting right in here.
That's the saphenous nerve, and usually there's nerve to vastus medialis, and I see a pulsating vessel.
Yeah, there's one tiny little vessel here, and I think there's also another nerve right here. Down the road from us, 10 miles away, the university that cannot be named, in Durham University, the guys there described using a nerve stimulator when you do this block to help you find and actually stimulate the nerve to vastus medialis. I think because there is a pain contribution, and any muscle that's acting in a joint should send a branch to that joint. Okay, that's Hilton's law from anatomy. I remember that from way back in medical school.
That makes sense.
So if you block that, you still get good quadriceps function and patients can move. It's also important you realise that's there, that if your plan is to fall along that fascial plane towards the artery, you can inadvertently hit the nerve to vastus medialis, and we'd like not to do that. Okay. Now, does it matter how high or how low you go in the thigh? I mean, it's been interesting. You go a little bit lower, you put a higher volume. Yeah. You might get branches that spread down through the adductor canal, and you'll get something that kind of resembles an eye pack. It might give you better analgesia and knee replacement. If you go a little bit higher, you get more of the branches of the femoral nerve. So people have argued one way or the other. We don't really know. There seems to be varying and conflicting studies. But what we're trying to do here is allow people to get analgesia and walk. And we've gone from the femoral nerve all the way to doing adductor canal blocks. And I think just this past month, we've come full circle. Somebody published a paper on knee arthroplasty saying femoral nerve block gives you the best analgesia. So you hang around long
15
enough,
years.
these things come all the way back around. What is your goal? So maybe if somebody's got high opioid use, they're anxious, degree of chronic pain, maybe you do a femoral nerve block. if you're trying to get people up and out, you've got an ambulatory knee surgery program, you want to get people out the door, do a distal block. People are now adding this in and looking for cutaneous branches and doing genicular nerve
Genicular
blocks
nerves.
as well. We can, the geniculars, sometimes I see them in elderly patients, sometimes I don't. What I'm really trying to do is the medial lateral side of the knee when I do this. Let's get the scan cam on that probe.
Okay.
And camera one, and then we can look. Sometimes you see a lovely plane as we come down.
Here we
Just
go.
right
That's a
hand
vessel
side, I
right
think
there.
you can see a little blood vessel just in here. So on a young model, healthy model, this block seems simple, straightforward. We'll place the local on just as you above the condyle there, and
That's
right
medial
down on the
genicular.
bone, and that's the medial femoral. We'll do a lateral femoral, and you can do a medial tibial when we're
It's a lateral
looking
femoral.
at these. Monica's now sliding there's the medial, and now sliding the probe across the lateral side, same part. Sometimes you see the blood vessels, sometimes you don't.
But that's the femur, and just
Yeah.
go and touch the femur, inject some
Touch
volume.
the femur, inject some local there. If you end up doing these superficial branches as described as well, if you go back to doctor and look superficially, just look above in the fascial plane, above
the
here,
sartorius.
you can often see little branches of nerve tucked in here. If you put local anesthetic in here, you can get these little nerve branches that are tucked in. If you slide across medially, you might find various ones in there.
One right
My
there.
buddy Jeff Gadsden ends up doing 9 individual blocks on knee replacement. Somehow I think this is being enthusiastic, and that's a lot. He says he's quick and slick. He can do that in a few minutes.
One more right there.
We still really haven't seen any evidence of the if that's going to make a big advantage. It's interesting when we're looking at sartorius. If you scan down and watch that artery leave, you can look at the sartorius muscle, and you can often just see the remaining saphenous nerve. So if I'm doing surgery beneath the knee, foot and ankle surgery, if we watch that's stuck down, often you just see
the saphenous nerve right there. Beautiful.
The saphenous nerve is tucked here on its own. Okay. And so we'll get a purely
right there
sensory branch here. And if you block it this high, you can get a nice block for looking at the knee. Somebody else, JM Toff's asking, can you show a patellar branch within the sartorius muscle? And you can just see it tucked in that fascia just in beneath, nicely here. Maybe a patellar is split, maybe it's running along with the actual main part of the main part of the saphenous nerve.
Does that look like a whale to you? A baleen whale, and just right under the nose.
Under the nose of the whale. Okay. So we love adding animals to all the different blocks. So we can see that, and this will just give you a sense. Of course, I'm going to use this when I'm doing surgery below the knee and combine this with a popliteal nerve block. What I want to do is I'm going to talk a little about place of being, and I'm going to swap out our models because we've got somebody who's got an empty stomach, and I don't want to really do nerve blocks. Let's do a little bit of scanning. So we can scan an empty stomach here, and then add a little bit of a little drink as we go. It's just a useful skill. This is an ASRA opinion. First Annie Perlas, who was on the board of ASRA in Canada, has pioneered this in anesthesiology. One of the most read articles in the ASRA newsletter is the how-to article, how to do gastric scanning. You don't have to be an ASRA member to see this. I'd love if you did join ASRA Pain Medicine if you work here in the United States. But we are seeing a lot of controversy with Ozempic, semaglutide, and other GLP-1 agonists, causing delayed gastric emptying. So we thought we'd just do a little bit of POCUS here and slide away from regional anesthesia. And do you want to turn onto your side? We'll just do this on your side so we can do this empty. And have you got your drink there beside you? All right, okay. We'll push your drink into your hand. So we'll scan you. We can do the live stomach fill up as we do this. Okay, so let's see if we can. We've got curvilinear
Oh, we're good.
on
Yeah.
here, Monica.
Yep,
Yeah.
we got a curvilinear
We'll
probe.
do the picture in
Gonna
picture
have
so we
you
see what's going on.
just
When
maybe
we
a little
put
bit.
this
Yeah.
on at the where
Okay.
we're looking at the zippy sternum, we're going to have this set deep because we're going to look for the edge of the liver, and also underneath we're going to look for the pulsating abdominal aorta. Lets us know we're in the right place. Okay. So I see a little bit air in her stomach here. Edge of the liver. Look a little bit for the antrum. We can see the pulsatile artery underneath. Okay. And here's the liver edge.
Yes.
Yep. And I can see a little bit of air in a stomach here. Okay. I don't see a big full stomach. I see a little bit air here. Okay. Front wall. Yep. Liver edge, abdominal muscles, pulsatile artery, so we know we're at the antrum. So let's see if we can get a model to drink some of our prepared. I'm going to reduce this. So hopefully she doesn't choke as she's drinking here.
In the lateral position.
Drinking in the lateral position, is that easy to do?
Is that a fizzy drink or? Yep. Okay.
Got a fizzy drink. Okay, so we should see some fizzy bubbles and things appearing in a second.
You can see the size of the antrums getting larger here.
So we can see this larger. Start to see some movement as this is filling. We're seeing, oh, look, there's little artifacts coming off here as we are seeing this. As the fluid starting to fill up.
Yep.
And this now looks at this is filling up with fluid. So we are now got a full
liquid full stomach.
Yeah, liquid full stomach. Now, obviously very nice. Nice shot there of a Monica. You had it. Yeah.
Okay. Guess you can stop drinking.
Yeah. No giggling because that moves the scanner. Okay, but look
I
at
can see all those shimmers.
all those shimmers coming off. And do you want to slide back into the body of the stomach as well here, Monica,
Okay.
just so we can see. And now we can see, you know, just a couple of mouthfuls and we can see some fluid starting to fill. Let's see right down here.
Right there.
Yeah. We can see the fluid now moving around the stomach. Yeah, right there. Nice shot. So just under the liver edge, we've got a little bit of air in here, which not gives us clearer pictures, might in some other patients, but you.
Now you can see.
Now you see
things
stuff
moving in the
floating
stomach.
around and floating around the stomach.
Yes.
Okay. So I think this is a really simple skill to practice, a simple skill to learn.
You can see this opening and closing.
Yeah.
The peristaltic movements of the antrum.
We just hold
actually
slowly.
further up here, right there.
There we are. Yeah.
It's
It's saying thank you breakfast.
yes, thank you fluid.
And
so all that water is gone.
yeah. So pretty quickly.
Yes.
Flowing through an empty stomach. But this is a superficial and easy one to practice. So I want to say thanks for everybody's been piling in. We're about an hour and a half into this, and I'm looking to hear. Somebody says axillary brachial plexus block, Iksang, Aman. Well, we started showing this at axillary brachial plexus block and its variations at the very start. So what we're going to do is put this up and leave this. There's a website. You'll be able to look back when the recording goes on the website. You can see all that. We started with the brachial plexus block earlier on. And I've got a little question here. Can we use a catheter and pen block for continuous analgesia for hip? How much volume do we need per hour for analgesia? Well, Iksan, I have not put a catheter in the pen block. I've used this principally for hip fracture patients, and very often they provide analgesia up to the surgery. And when the surgery's done, Most of our patients, they want them ambulating, and most of the patients, when the bone is fixed, the pain from surgery usually settles, and you know, early the next morning, the day after surgery, they want these patients ambulating. I've not put catheters in. It's quite a tight space. I don't know how easy it'd be to leave a catheter in there. If I'm going to put a catheter, I'd probably put a suprainguinal fascia iliaca block. It's further away, and also further away from where the surgeons are operating. Maybe if you had a patient who's a palliative patient, then they're not going to do the hip surgery because the patient's other comorbidities, possibly you try putting a catheter in there. But I don't think I would end up doing that. Somebody asked, articular shoulder branches block. To be honest, it's not something I do. More something we see for chronic pain. There's a great paper describing that in RAPM for chronic pain. We will actually look for the suprascapular nerve underneath the supraspinatus muscle, and we can have a little look for that. And that's something we can do. And as I said, we also combine that with an infraclavicular brachial plexus block. So maybe we turn our model away from us, and we can look at the shoulder. We get somebody on the scan cam. Put the light on the scan cam, right?
Okay, so the landmark here.
So let's you lay down your side so your back to us, okay? That'll make it easy for Monica to scan.
Okay.
And
Perfect.
okay. I'm
Okay.
going to bring the camera up a little bit more careful.
Yeah.
Fantastic.
So you feel for the spine of the scapula, above which would be your supraspinatus muscle, and below which would be your infraspinatus muscle. And that's the acromion I can feel right there. So you're going to put your probe right north of the spine of the scapula. And we are trying to look at the suprascapular notch. A little more depth here.
And Monica's got the probe at vertical. Quite important when we do this that we have the probe quite vertical. If you flatten the probe out too much, there's a chance you can slide through the notch and cause pneumothorax. So hold the probe vertical, and she's got a lovely
supraspinatus, yes.
over to our view, sorry. With a lovely view of a hammock here, supraspinatus muscle here. Trapezius above that, and we got like subcutaneous tissue here. So supraspinatus, looking at this, and I usually tilt back and forward. Sometimes you see a little split at the bottom. I'm going to give you a little bit more depth. Oh no, you actually got it there. You can see a little split and a little fascia. Sometimes the blood vessel visible, sometimes they're not. If we put in color, we might see a little blood vessel down here. Often I don't see that. I do see that fascial plane there, Monica, but I don't see I don't necessarily see the nerve, but I'm going to place. Now, if you just show us from a lateral end in plane where you probably place your needle, we use the pen for needle. You can do this in plane or out of plane. You see Monica's coming from the lateral end with a needle. Or you can just do an out of plane and mark the depth. If you know about 3.5 centimeters out of plane, you can just plumb bob straight down, place your needle in the bone, aspirate, and then inject 5 to 10 cc's for this suprascapular nerve block.
And the nerve travels right on top of that bone for some distance, because it comes from the brachial plexus anteriorly, gets into on top of the scapula via that suprascapular notch, and that is going to travel under the supraspinatus muscle until it comes out laterally via the supraglenoid notch. So anywhere in this area under the supraspinatus muscle, what volume do you usually recommend putting here?
5 to 10
5 to 10 cc's is
10
usually
cc's
going to be, it's going to cover that nerve. So.
And I use 0.25%. So I'll always harp on about this, but this is just an analgesic block. We're not using this as an anesthetic. If any nerve block you do combine with GA, you can go down to 0.25% ropivacaine, 0.25% bupivacaine. even 0.2% ropivacaine just to get analgesia. I'm not trying to get an anesthetic block in these cases. I will go back to our ultrasound picture with this one. Let's look again. Just focus on how vertical that probe is. So if you're standing behind the subject to do this, you want to make sure that probe is vertical. That's a safe way to do this block. If Monica flattens it out, flatten out a bit more, flatten out a bit more, I don't want to see that. I want to make sure the probe is vertical. That makes this block safe and make sure we're in a safe place when we do this. We are going to carry on with our scanning on our side. Do you want to do so like some of the abdominal muscles?
Yes.
And we're going to go on. Somebody says paravertebral block here. Well, do you want to go from the thoracic paravertebral, and we can show that?
Okay.
Let's turn over to a curvilinear
Yeah.
probe. Okay. So Raja says paravertebral block, please. So he's only got a 3-leaf clover rather than a lucky 4-leaf clover. But we'll go across and let's look for a paravertebral block. So we've got our model turned on their side. We usually use a superficial. Use a curvilinear probe for this one.
This is great. That's fine.
It's difficult in most patients to use a linear probe. Okay. So we'll get things positioned for this. Get the camera position, the scan cam.
Okay. So I'm feeling.
Get that camera on there. Monica, where are you?
Okay. So this is approximately third thoracic spine. So I'm in the midline here, and I'm going to put the probe. Just lateral to that.
Okay, just lateral to midline. And
let's push the probe here.
Some probe plugged in.
Yeah, it's plugged in. Sometimes it takes a while.
Yeah, take a
there
second. Okay, we've got our image. Ultrasound image on. Picture on.
All right, I think it's too bright now.
Yeah.
Okay. All right. So there we go. So you want to see the distinction between the ribs. So I'm going quite a ways laterally now. Okay.
And there's the pleura.
That's the pleura. I guess can we optimize the image? Can we put it on the nerve setting?
Okay,
yeah.
Let's change. We're going to change this. We had this in NSK setting, so let's put this onto nerve. Okay, and scan again. So we're just changing. That looks a little bit better. Got a little more muscle definition with that one.
Yeah. Okay. So going lateral, this is, you can see the ribs have a rounded edge to it. And you can see the pleura very clearly. As I'm coming more medial towards the spine, you will see the ribs ducking under the transverse process and the transverse processes appearing as a very flat top.
Squarer here. A little bit more lateral again.
Lateral. That's rib.
Rounded rib.
Transverse process. Right there. That's the transverse process.
Okay, nice. Square one here.
So when we do an ESP block, we come and stop short right at the transverse process level.
Yep.
And we inject local below the erector spinae muscle plane. I'm going to show how we do the intertransverse process, or previously it was called a mid-transverse process block. And over here, inferior is to the right and superior is to the left.
Superior.
Yep.
Inferior.
So traditionally, paravertebral block was done with popping through the costotransverse ligament, which comes from the rib below to the transverse process above. And so if this is below and transverse process above, you will be able to see a costotransverse ligament. So above the rib, above the transverse process, it would be more superficial, and below the transverse process, I'm sorry, the paravertebral space will be more superficial below the transverse process, under or caudate to the transverse process. So if you're coming from here and we're aiming to go in between the midpoint, you can see the transverse processes and you're seeing the pleura. And if you put your needle somewhere in between these two landmarks, so the top of the transverse process and the pleura, and you put your injection right there in the middle. If you stop short right there, you will have what is called an intertransverse process block, which is, now we know there is evidence that the costotransverse ligament has openings which would allow the local anesthetic to traverse to the paravertebral space, which is anterior to that. So an intertransverse process block is just as good as a traditional paravertebral block.
So you don't have to go right down onto the pleura.
You don't have to go.
to
You don't have
go
to
too
look
close to the sun.
exactly
Yeah.
and poke the sun.
Yeah.
So this is what we typically do at our institution is we just go do an intertransverse block with very good results. And
If you can't see anything, bail out and do an ESP as a simple solution. If you're unhappy, I can't identify the pleura, I'm not sure where I'm going, you can make things safer by doing that.
yes. Caution is, this is a block where local anesthetic is going to travel to the path of least resistance. So we're traditionally used to injecting large volume at the ESP level, whereas we've done cadaveric studies where we've injected, when we inject 20 mLs, just like an ESP block at the intertransverse level. When we dissected these cadavers, we saw pretty extensive spread on the posterior surface of the spinal cord. So there is a very good epidural spread. So just remember to treat this block, the intertransverse process block, like a paravertebral block and inject small volumes at each level as opposed to injecting a large volume at a single level. Okay.
Yeah, I think this is a great one. Thanks very much for everybody who's contributed in the chat, and thank you for interacting with us. We're getting to the last 10 minutes or so we've got for scanning, and one of the last comments here is, since we're in this position, it's going to be easy. Christine Vuas show spine ultrasound for neuraxial procedures. Can we identify the epidural space?
Okay.
Okay.
All right. We're going to go lower back here. So.
And just following on what we've just shown, GM Top asks, do you go more medial so the pleura disappears with PVB? And I used to, I don't anymore. Interesting, we went into cadaver lab, and when we were looking at where the local goes with that, at intermediate position in a PVB, when you put a large volume, the local doesn't spread up and down the paravertebral space. It actually goes medial and goes into epidural space. So you get a multi-level spread by volume by that mechanism. The other way, the downside is that as you actually get spread to epidural space, you get hypertension. You always know you get hypertension with paravertebrals. If you go a little bit deeper and you go really down onto the pleura, I think you actually do then get spread through that paravertebral gutter. It's like a separate mechanism depending where the needle is. So that midpoint between the transverse process and the pleura, a large volume spreads medially, spreads in the epidural space. If you go right down onto the pleura, I think you do get some spread, Kepler caudate in that gutter. So it all depends on where your needle goes and what your endpoint is and how many levels you're trying to achieve. Just remember, any of these, a large volume, multiple levels, can lead to hypertension. That might not be a problem with unilateral, but if it spreads centrally, you get epidural spread, particularly in a thoracic surgery patient, maybe less healthy cardiovascular system as well. That can be a trouble dealing with hypertension during the case. So just try and balance that. The other thing about going closer to pleura is there's a chance for maybe not a problem thoracic surgery.
You're good.
You need to drop the lung. That might be a little more tricky if you're using that in a breast surgery case where you certainly don't want that to happen. So Christine said, can we show some of neuraxial space? So So let's get camera one on our subject's back just to show
Okay.
where the ultrasound probe is. Okay.
All right. So we have the model in
Transmitters lying on our side.
lying on
Yeah.
the side and knees pulled up. So we have opening of the spaces in the back.
Go to the camera and
Okay.
do the picture
So
just to show folks.
what I'm doing is I'm going to scan from bottom to up. So we're going to scan at the level of the sacrum, and then we're going to come up. So I am slightly paramedian and pointing inwards, and we are looking at the sacrum right now. And
They're going a little bit caught up to show sacrum. Yeah, there we are. Linear, the sacrum here.
mhm.
This looks like it's 5. And look, there's L5S1. We can see the gap here all the way back here down the bottom. This is the sacrum. This is 5, and we're looking this paramedian window. We can see the L5S1 space, and we're looking back at the posterior complex. This is the back of the vertebrae. This is the posterior longitudinal ligament. So Monica's got a shot where she's looking all the way right through. We're stuck in the middle here. I almost see something dark. I can convince myself that's the thecal sac in there, and this is the back of.
And you're seeing very similar at L4.
Yep.
Yep.
Yeah, we can see again L4.
Right there.
Yep.
So anytime sound waves can travel through there, you know, your needle can travel through there.
Yeah.
So, so the approach is usually I try and mark out a favorable space. So let's say I'm going to at the level of L3-4, which will be this right there. And I'm going to center that and then mark the center of my probe right here.
I'm going to go to camera and show us how you change the probe position to center this. So she knows the level.
So I know the level right here, and now I'm going to rotate my probe.
Okay. And we'll show the ultrasound view. We've changed this over, and I can see Monica's not quite center of the ultrasound probe, and now she is. I can see the shadow.
And that's the spinous process right there, and you can see the erector spinae muscles.
Move it off the side again, Monica, just this shadow off the side. Okay, so you might some patient who's got a scoliosis, lordosis, you might find that things are off the side. And you have to tilt your ultrasound probe to get that in the center. This is number one, you find the midline. And we already know we can see through here because I've shot through before.
And then you can play with your tilt and see what tilt will give you the best image of the anterior complex. And right here we're seeing going all the way through, and I see you can see my probe is tilted a little bit cephalad. So you can assume that your needle, when you go in with this angle with your needle, you will hit your epidural space, your ligament of flabums, right about here.
And you're the same as me. You don't do this real time. You mark, put the probe down, and then do the spinal or epidural.
Most important thing, when you mark the patient, you have them sitting in the exact position where you want them to be when you're doing the actual procedure. You don't want them to mark them while they're sitting up and then have them slouch to do the procedure. So mark them in exactly the same position where you would be doing the block.
Yeah. So when we're between them, and we see the gap, we're seeing the shooting all the way through here to the back of the vertebral body, we can actually see a little bump here of the facets where we get this overlap. If Monica were scan Kevlar or Kodak, she might not be able to shoot all the way through, but what she will do is she'll see a more prominent
articular process.
Yeah, we had the articular process there, and now we're getting on to the
lamina. Yeah.
If you goes back down to the gap, you can see the little knuckle, the bump of that articular process, and that's obviously between the vertebrae above stacked on top of the vertebrae below. The articular process is there between them. We'll shoot through the ligament, and we can almost think we can see the front of the thecal sac here and the back of the vertebral body.
Yeah.
So great for finding the depth. If you've got a patient who you're unsure how deep you want to go, it's great to find where there is an open space. And that it's interesting. The first thing Monica showed us when she came off the pelvis, she came up the sacrum, L5S1 in elderly patients, hip fractures. Often that's the only space that I see that is open. So caution here, your block might not spread as high if you put your local in L5S1 as it would if you go L3-4. maybe put a little bit more local anesthetic. But often in a difficult spinal, that's the only space that I see that is open when I scan the patient. So Monica's gone back into that sort of view with the probe lying vertical, and we'll have a look at
There
the
we go.
ultrasound, and we can see the shooting down and the light coming all the way down here, okay, on the back of that complex. Again, back here,
So going back to sacrum.
yeah, this is sacrum,
Mm-hmm.
yeah. And if she just tilts, we can see the gap all the way down here, L5S1.
Yeah.
So we can just see that the light shining at the bottom. We've got other requests we've not managed to fill. Our time is getting short for us. We have got our own workshop here for faculty and residents and fellows. So we are going to go next door and do a couple of hours and really do our own local workshop with contestants. I want to say thank you for everybody's tuned in. If you're interested in learning more regional anesthesia, ASHA's got courses all throughout the year. The big events coming up for the ASHA Pain Medicine Spring Meeting this year is in San Diego. Still time to rest, there's still time to come along and enjoy. And there's also a workshop that ASHA puts on. If you're tuning in from further afield, I do know I'm going to the RAUK conference in London in May. And then Ezra's got, of course, its own regional anesthesia meeting. You know, I'd love to stay in contact. We'd love to hear how you celebrated. Please leave comments in the chat and YouTube. Please reach out to us, Monica and myself, on Twitter or through here at the University of North Carolina, Chapel Hill at UNC. We hope you had an informative morning, and I've really enjoyed this first World Day in Regional Anesthesia and Pain Medicine. It's been amazing to wake up here in America and see on Twitter people from all around the world who are celebrating this event. This event's being recorded. We're going to put it up on the ASHA YouTube, ASHA Pain Medicine YouTube page after we're done. And enjoy the rest of this first World Regional Anesthesia and Pain Day. And hopefully next year it'll be even better advertised, with more centres getting involved. I'd love to hear what you've got planned for your event next year as well. Thanks, Monica. Great scanning.
It's a great start, and we are very, very thankful to all of you for joining, and happy first World Regional Anesthesia Day.